Okay, so good morning, everyone. We're live from this episode of Monty Heart on January 21st, and we're very excited and honored to have with us here Dr. Akiko Mehara, Professor of Medicine at Columbia University Medical Center. Her training span all the way from Japan to Stanford and Washington, D.C., and she's been now one of the gurus in intravascular imaging for coronary artery disease percutaneous treatment. And we are very, very, very excited for the lecture that she's going to give to us today, which is entitled IVUS for PCI in 2025, Drug-eluting stents and drug-coated balloons. We're really, really eager to hear from you, Dr. Mehara, and thank you again for joining us today.
Good morning. Thank you. So I promise today I'm going to be very provocative.
Fantastic.
Okay, so 2024 ESC guideline for the management of the CCS, intracoronary imaging guidance by IVUS and OCT is recommended for performing PCI, anatomically complex lesion, in particular left main stem, true bifurcation, and long lesion. This is finally class 1 indication. And that's, I talk this really complex lesion and what should we do for the simple lesion and others, etc. as well. And this is the most updated meta-analysis, including the intravascular imaging versus angiographic guidance for the DS in the randomized trial. And this is a target lesion failure. And you can see by using the intravascular imaging, about 30% reduce the target lesion failure. That's very clear evidence up to now. And let's see two randomized trial. Number one is Renovate Complex PCI. That's including 1,600 patients. Either IVUS and OCT was used compared to the angiographic guidance. Primary endpoint target vessel failure, you see the imaging guidance reduce the primary endpoint. Importantly in this paper, this is the first single study to show the reduction of the cardiac death is about 50%. And in this study, complex lesion subset was defined as unprotected left main, CTO, severe calcium, long lesion, true bifurcation, and ostium lesion. So those so-called complex lesion is actually quite consistent in the different randomized trial. And importantly in this paper, they allowed to use IVUS or OCT based on the operator's preference as well as the lesion subset. And I do think that's probably the best way to use because those imaging has to be complementary. I would show one more study, which is actually provocative. This is a GUIDE DS trial from South Korea. They include relatively simple lesion subset, such as syntax score is 13, and reference vessel diameter by QCA is about 3 millimeter, and ultimately the total stent used is 35 millimeter. For us, this seems to be relatively simple lesion subset. At 1 year, the overall event was quite low, and they compared the online QCA guidance versus IVUS, and they show the event rate was low and not difference. So if you are looking the relatively simple lesion in the current era, do we need the intravascular imaging for all of them, or somehow QCA can be used better way in the clinical practice? Those are the questions which we should answer. But let me go through two cases to make more discussion. So this is a case, you can see the very severe distal left main and ostial circumflex. And obviously, there is a very clear calcium in both regions. And we did the IVUS from the circumflex, and nice calcium at the ostium of the circ, and this is LAD, this is distal left main, and this is proximal left main, which is huge. One more time, This is an osteocircumflex, and LAD is on the top, and this is a distal left main, and this is a proximal left main. So to summarize, actually this case was quite surprise. I measured the minimum lumen area in the distal left main, which is actually 10, and osteocircumflex is 5.2. Because of the oval shape of the lumen, we look into this way, and then compared to this diameter, we see this is quite significant. And the exact same for the circumflex, we compare to the proximal circ, which is big, and this diameter, and then we say this is quite significant angiographically. But when we look into the IVUS, we see the lumen was actually good enough. On top, this is a very typical so-called eruptive calcified nodule. You see the calcium, which is hyperintensity and acoustic shadow. But on the top, the calcium is regular and also protruding to the lumen. This is typical calcified nodule. So altogether, clinically, what should we do? And should we do the IVUS guidance? And actually, yes, this is IVUS guidance. And based on the IVUS guidance, we thought, in terms of the distal left main, this is a data from South Korea, compared to the isolated left main IVUS measurement versus FFR, and the cutoff value to predict FFR positive is 4.5. And based on the clinical outcome, if we differ based on the MLA is more than 6, looks like deferral is safe. So based on those data, maybe we say less than 4.5 we should treat, but more than 6, okay, in between we should consider based on the patient characteristics. And back to our case, that was 10 and calcified nodule, so we thought we should not treat. Why? Because this is other data. Based on the OCT, we compare the calcified nodule outcome compared to the non-eruptive versus eruptive, and they are actually quite poor outcome after stenting. At 1 year, if that is eruptive, the recurrent rate is 10%, and that's really concern. And this is another case example when we are treating the eruptive calcified nodule, and you can see the before PCI clear calcium. And we did this case by OCT. You see the calcified nodule inside the lumen. After stent looks good. But 5 weeks later, when we treating the staged procedure for the LID, right coronary artery, you see the similar findings. And then when we perform the OCT, there is a protrusion. But I was concerned this is really the calcified nodule, or could be the thrombus. There is a lot of debate during the cath lab, in the cath lab. And actually we opened the IVUS, and then we confirm that appearance is actually calcified nodule. So I think when you have the doubt whether this is really the calcified nodule, you can see the IVUS. That's probably the definitive answer. But anyway, come back to the current. This case was because of the treating the eruptive calcified nodule. It's actually identified a poor outcome because of the reprotrusion of the calcified nodule through the stent. That's making the poor outcome. So come back to our case. That was angiographically looks very severe lesion, but when we did IVUS, it was not because of the oval shape. Additionally, we see the eruptive calcified nodule, which we confirm that's poor outcome, like this type of the case. So altogether, by IVUS guidance, we defer the treatment. That's probably the way in the current era. The second case, which is also very provocative, this is 81-year-old female and shortness breath. Angiographically, you see the old stent which is patent in the LAD circumflex, but distal left main, there is no stent. This is only the calcified lesion. And you see the significant lesion in the proximal LAD as well as ostium. And our concern was maybe this is connected to the left main. How should we do? And other big question was how should we do it on the circumflex? And in this view, we thought not very clear what's happening in the circumflex and also the very old patient. And altogether, based on the angio, our idea was provisional stenting. That's what we thought. And we did IVUS in the LAD to the left main. As we expect by angio, there is a very clear stenosis in the proximal LAD, which is actually calcified nodule. In the distal left main is 5.6, which is for the small female patient could be borderline, but if we treat the LAD, better to crossover. That's what we found. And more surprise is actually circumflex. Angiographically, we thought it's okay. But number one, the left main is consistent, it's calcified nodule, it's significant. But when we look into the circumflex, it's actually quite severe, 3.7 square millimeter. And also, you see the circumferential calcium. So what we should do this type of cases? And that's actually quite surprised. And we already decide to using the IVL in the LAD because that's very, very severe calcium. And we thought we should treat the circumflex with IVL first. We go ahead to do the IVL into the circ and using 3.5 for atmosphere. And this is the result. Before and after IVL. And you can see nice calcium fracture in the both sides. And we see the lumen was probably acceptable. And we didn't make the non-flow limiting dissection. And we thought this is quite ready to crossover, meaning the circumflex treatment was done. That's what we thought. Because that looks like the controlled dissection in the severe calcified region. And additionally, there is one more discussion about this case it's a different case. So when we crossover to the LA to the left main in such case, we worry the carina shift. This is a different case. You see the severe stenosis in the LAD and the left main. After crossover, you see the pinch of the circumflex ostium, which many times we see. Why this happens is so-called carina shift. This is IVUS picture on this case from the circumflex to the left main. Before crossover, it was actually good lumen and actually normal area. After crossover to the LAD to the left main, circumflex ostium was pushed from the LAD, and because of the oval shape, by looking this way, we see the very stenotic. And this happening relatively normal ostium of the circ. More likely happen in the normal segment. Then we thought our case today is really very significant calcified region in the osteocirc. And we saw this is almost natural stent. So as long as we are treating the flow limiting stenosis, and we have kind of natural stent. So if you cross over to the LAD to the left main, actually we have better chance not having the carina shift compared to this type of the normal circumflex ostium. That was our idea. So based on this, we go ahead to treat the LAD using the IVL and post dilatation and long stent from the LAD to the left main, and POT and proximal LAD is non-compliant. And those treatment was all we decided based on the before pre-IVUS because those measurement was done. And then this is how it looks like the IVUS after the LAD treatment. And after the IVL and stent balloon, and you see the osteo LAD was nicely open, 8.6, and the left main huge, and 11.2. So this is a final angio from the LAD to the left main, and also you can finally see the circumflex. This case, we didn't crossing the wire into the circ, we didn't open up. Considering all findings, patient is relatively old, and also that we expect, we did the control dissection, and we treating the circumferential calcium. And because of the calcium, we expect not much carina shift. And altogether, we decide this procedure. But we discussed, this case was done last year. So if we have the drug coating balloon can be used for the de novo region in the side branch, maybe we should do the drug coating balloon. And altogether, this is a current discussion, what is the best strategy of this type of region. So altogether, it's really, for us, it's really how can we predict the outcome of the entire procedure. So let's step back. For the young people, young interventional cardiologist, step back the basic. So what is the most important is calcified plaque, seeing the hyperintensity on the surface and acoustic shadow, and no hyperintensity but attenuation, that's lipidic plaque, or everything else. So we can clearly differentiate what is important morphology, making the good prediction of the stent outcome or balloon outcome of the atherosclerosis. In terms of the calcium, we have to differentiate superficial calcium versus deep calcium because deep calcium does not inhibit stent expansion. Additionally, we have to check whether the circumferential calcium or non-circumferential, that's important. And the calcified nodule, which we discussed, irregular surface and protruding to the lumen, that's different outcome. Additionally, after the preparation, we really have to confirm the calcium fracture before stenting because otherwise we never ever expand this type of the circumferential calcium. How can you identify the calcium fracture? Is really looking for the outside of the structure. This is the exact same frame. You see the circumferential calcium, you don't see any structure because of the acoustic shadow by calcium. But after fracture, you start seeing the outside structure that's indicating there is no calcium no longer on the top. So by looking at the fracture, this case, we treating the cutting balloon, and you see the both side is calcium fracture, and that's very important. And then we put the stent, and we should never ever expect after stenting into such calcified region, getting the very nice round shape of the lumen, never, because we cannot change the calcium surface. And we see many times this type of the funny shape of the surface or stent expansion. That's okay, as long as a good stent expansion, they are good outcome. So those are the really the prediction as well as confirmation what we should have done. Additionally, let me step back one more time. This is which we propose in terms of the calcium score, because what is the key of the complex lesion, especially the calcified lesion treatment? We really have to look for the entire amount of the calcium, not only the one slice, but also the total length. And based on our clinical practice, we really develop the calcium score, not only the circumferential, but also you should look for the amount of the calcium longitudinally, if that is longer than 270 and longer than 5 millimeter. This is just like the cutoff, but don't worry the number. It's really, you have to look for the entire region. And then if that is long, big, that has to be considered. And additionally, the presence of the calcified nodule indicating the poor outcome, as well as that this is the marker of the big calcium behind. And finally, the vessel diameter is important because vessel wall tension by doing the ballooning is different compared to the small and big artery, because based on the Laplace law, the wall tension is correlated with the vessel size. So if we have the same pressure in the middle LAD and the left main, there is better chance having the fracture in the left main because of the vessel size. So those also take into account whether we should do more aggressive if that is starting the small artery. And we show if you have the high score, more calcium, doing the additional therapy makes sense. But if you do not much calcium, actually doesn't help too much. So those are the important for the prediction. And additionally, I think we should consider this type of lesion. This is a very long lesion, and we did IVUS. And then, as expected, it's really diffuse lesion, and we measure. Looks like we have to put a long stent. And I remember this case, we put a more than 15 millimeter stent in the such long LAD and crossing the low to diagonal branch. And what we should do this type of lesion. And if we treat long lesion, this is our data based on the about 400 in-stent stenosis evaluated by OCT in terms of the prevalence of the neoatherosclerosis. So if we look into the in-stent stenosis, which was more than 5 years after the stent implantation, the prevalence of the neoatherosclerosis is 30%. And if the stent is older than 7 years, it's about 75%. So it's really, we are making the new disease. So those we have to consider as well. And additionally, again, this is also by OCT data, which we are going to publish soon. And this is really based on the clinical observation, meaning when we look into the old stent cases, I see the calcified nodule at the stent edge more often than de novo lesion. And then we analyze about 1,000 cases which old stent, and then ask the question, if we put the stent, can we see more calcified nodule at the stent edge compared to the de novo lesion? And the answer was yes. It's about 50% of the time. When we put the stent into the calcified region, we see the calcified nodule. So those together, we really have to consider what's the best strategy to treating the complex lesion subset. And then let's talk. It's this very provocative paper, which I think actually I discussed today, and I do think it's important. Based on the data from Dr. Colombo, this is a retrospective study, and they including two different treatment strategy. One is long DS treatment into the LAD, like that case which I show, versus long LAD treatment using the drug coating balloon and drug eluting stent. They are not trying to putting the drug coating balloon in entire LAD. Important proximal segment using the drug eluting stent, only the distal segment, diffuse disease, drug coating balloon. That's a strategy. And total stent length was 56. And if you do the hybrid strategy, stent length is shorter and using drug coating balloon together. And this is a propensity score matching data. And you see the DCB cohort is better. And I really emphasize this is propensity match and retrospective study. There is a lot of confounder, but I think this telling us something important message. This could be we should consider in such diffuse disease using the stent as well as drug coating balloon. And I didn't believe that paper a lot, but I think based on this case, I was surprised, and then I changed my mind a little bit, and then I was talking today. So this is a case which this case was done by Dr. Colombo when he was in Brazil. I was there, and we are talking together. And then he treating like that paper, and then long LAD lesion, and distal segment, I see the very nice hematoma. And I couldn't imagine how can leave it alone this type of hematoma. But he bringing the cutting balloon, and after the cutting balloon, you see the nice cut. And this is really the control cutting, and you see the hematoma disappear. And then we could leave it alone, this type of the lesion, and treating the drug coating balloon distal segment. So those are the additional idea which we should consider based on the imaging guidance. And ultimately, what is really the important for the prediction of the future event based on the PCI optimization? In the previous data, which including many like imaging data, and really telling us the two important messages. Number one, stent expansion is the most important. And number two is its issue is important. So because of this type of data, we are treating the dissection if there is found in the distal proximal segment. And then typically, based on the previous like ADAPT-DS data, we show what type of the dissection is important to cover. And then based on our data, we are talking the lumen has to be 5, and plaque has to be larger than 60, or length is 3 millimeter. So-called large long dissection, we should treat based on our data. That's is still true or not. And this is the data from the Illuminium 4, including 2,500 patients, to ask the exact same question. Including all OCT data at the end of the procedure, what is the most important parameter to associate it with the future event, including 2,500 patients? And very consistent. stent expansion is important. That's whatever we using the outcome, that's the most significant predictor. On top, edge dissection, which occur in the proximal edge. But I would mention a little bit. And this proximal edge dissection is any dissection, not only such big dissection, but also the small dissection as well. And then we wanted to be careful to deliver this data because we don't want to over-treat of this type of the lesion. And what are we looking at here? Is my expectation is probably we are looking some disease because of this. On top of the disease, if we have the dissection, more likely the stenosis. So are we treating the residual disease or are we treating the dissection? So altogether, I think I would ask one more time, what is really the flow limiting dissection based on the imaging we should treat? Or should maybe we are treating too much in the past? Those are the really good discussion based on the drug coating balloon which we have in 2025. And finally, I think this is last picture, which is quite important. I'm going to show the 4 different case. And everything is instantly stenosis, and we have no idea what we should do, what's happening. And really, that was telling us what's happening inside. The most left is actually this stent was implanted in the myocardial bridge and very underexpanded, small neointimal, which causing the such bad instantly stenosis. This is actually good expansion and mainly neointimal aplasia. This is at the site of the kinking of the circumflex and making the stent fracture and the stenosis. And the last one is, as I showed before, this is the old stent, and inside of the stent, you see the calcium, which is neoatherosclerosis. So those are the completely different type, and decision should be very different. So before looking at what's happening inside and treating instant failure is really bad. And so I think the intravascular imaging is necessary. Okay. So I think that's my very provocative talk today, and I'm looking for the discussion. But to summarize, IVUS for the PCI in 2025, DS and drug coating balloon error. I think that really now we have the definitive strategy for the complex lesion. Intravascular imaging must be used to achieve the optimal result. And I think what is the importance of optimal result is really the prediction. Look for the morphology, especially in the calcified region, and making the good prediction. Should we do the calcium modification before stent? Those things can be predictable. And I do think that looks like simple lesion. I think intravascular imaging should be really considered in any suspicious for the complex morphology or complication. And especially for the young interventional cardiologist, I think we recommend to do the simple lesion first and be familiar for the intravascular imaging. And then when you are getting better, you can choose when I really need the intravascular imaging. And this is my final provocative message. I do think we may need to reset our mindset for the flow limiting dissection to maximize benefit of the DCB along with intravascular imaging in 2025. Thank you very much.
Thank you, Akiko. That's excellent. Pierre, go ahead.
Yes, no, absolutely. Thank you so much. There was a pool of absolutely stunning images that really can be helpful, especially to young interventionalists. And I think you touched upon very important questions and matters that we encounter in everyday practice. The osteocircumflex lesion that we are always thinking about treating, the eruptive calcified nodules. You also showed us very good data from some initial experience with long lesions in LAD and DCB and the S hybrid strategy. So I think this was, thank you so much. This was a fantastic lecture. And I'm just curious, whenever you encounter stent fracture in intravascular imaging and you want to treat it, how does your treatment algorithm differ with respect to what you would do, for example, for an under expanded stent. Do you do anything different? Would you suggest anything particular? I'm just curious because, you know, whenever we encounter that, I think it's important that we tackle it the right way.
Thank you. I think like the two things which I would emphasize. One, let's step back. Where the place we see the stent fracture, we know it's a place where the very big hinge motion, like the osteolyte coronary artery, like the case which I show, that circumflex was almost like bending portion. And we put the stent and we see the fracture. So I think like the out of entire cohort, I think there is some specific segment which we expect more likely fracture. And in such place, especially like the circumflex ostium is also very frequent place having the fracture. And in such, putting two stent strategy is a good thing, part of the distal left domain or not. So I think actually we have to step back before stenting. If we expect that the place is really high risk of the fracture, we should step back and then consider should we stent, considering the benefit and poor outcome. But I think if we consider the overall rate of the stent fracture or causing the failure is still much less compared to the entire cohort. So I think putting stent still the first line of the procedure. In such, I think when we look into the imaging, I see there is a two different type of the fracture. Number one, it's complete fracture, meaning that you don't see any stent in the middle of the stent because of the complete separation, like what we see in the like the cipher or more likely six strat error we see often. Those type of the fracture, because why the stenosis occur is because of the no longer radial force to pushing the lesion, and in such we may need to put additional stent. That's one thing which we should consider. But many times, especially in the more than second generation stent, like the Zions or Resolute, whatever, what we see so-called overlap type of the fracture, meaning like almost like the inside of the single stent, there looks like fracture partially in some point, and then they are overlapping each other like this. And the case which I show in the circumflex was there is no segment missing stent strat, but looks like double layer of the stent, even the single layer of the segment. And in such, putting one more stent seems to be not logical because getting worse. And in such, that case, we just balloon, and then at that time we didn't have the coating balloon, so we didn't. But I think the best strategy is we balloon and the coating balloon. So I think it's based on the pattern, what we see. So based on this, we can decide. But I think anyway, whatever you do, I think the outcome after the fracture is not very good. And then we have to consider the bypass is an alternative as well.
Akiko, I have lots of questions as usual, but I'm only going to ask one for now because maybe the rest of my team are going to ask the same questions. So I don't want to take it away from them. So here's my one question for now. So, at Monty, because of people like you and Antonio, we've become a very high usage of intravascular imaging. So our average is above 90% of cases get intravascular imaging. So very similar to Colombia, I think. I think we're outliers. And so I'm very proud of our team. They always, if they don't, they always put an IVUS catheter in. Simple, complex, all lesions. Because we believe we learn, right? One of the things I always love, a saying that Colombo had, and you highlighted it for me when you did an analysis from Excel, is that the catheter doesn't work by magic. You don't put it in and put it out and say, oh, I did imaging, now I'm going to have a better result. You have to use the information to change your strategy, all right? So I remember you did this analysis from Excel that said that after imaging, the operator did something else in 50% of the cases, right? It changed the strategy. Is that still true? And how do we, we want people to use the imaging more, but we also want them to use it to make decisions, not just to look at it, put it in and put it out.
Good question. I think it's true. But actually, I do think that depends on the who asked that question and what type of the region are you asking for.
Okay.
So Excel is about 50%, they changed the strategy. But when we go back to the WDS, that was changed 75%. So
Wow.
it's really background experience and also the population. If the population is more complex, more chance having the changing the mind. But if you go into the simple region, could be less. So that's, I think, the always happen. I think what is the most important, especially for the young interventional cardiologist, you should ask yourself, what do you expect inside based on the angio, based on the patient characteristics? And then when we look into the image, and then if everything was as you expected, you good. But if not, especially the changing your mind type is really the learning point. And then our eyes for the imaging as well as angio evaluation is getting better and better. That way is also true post stent. You don't understand why this happened, and then you check the IVUS, and then you found something different, and then you change your mind. So those like prediction and confirmation, and then making better and better interventional cardiologist. So yeah, that's my
No,
yeah.
thank you. I think that's an important point to highlight. I'm going to wait for the rest of the team to ask their questions, and I'll ask my other two questions. Pierre, do you want to lead the?
Yes, absolutely. So let's see. We have a very numerous panel today. I see Andrea McNulty on.
Yes, hi, good morning, Tamara. Thank you very much for a great talk. I also have a provocative question, if you will. So we're adopting a lot of new devices that are modifying the plaque. I mean, we're using a drug-coated balloon, we're using IVL, we're using cutting balloons, but we're really not seeing the plaque. So the first question is, and it's again provocative, it's do you think that in the IFU of these devices, we should put, or there should be a mandatory IVUS or a mandatory intravascular imaging to use them? I don't know, there's a lot of implication, but I'd like to know your thought. And the second question comes from this is, what do you think, if there is one single cause, or what are the main causes why the adoption of IVL is so difficult to become, why is it so difficult to adopt intravascular imaging in the US?
Okay. I think why this is so difficult to adopting the intravascular imaging, to me, the most important is money. I think that's really
Always
really,
money.
yeah, that's to me it's true. But actually last year I visiting the multiple hospital teaching the IVUS, and then I see the change, meaning like people understood. Looks like data is true. And they're adapting more and more. That's I see more and more. And one of the reasons was actually like AI type of the beta too, like the Boston Abigo or like the Abbott Luteron. That's much easier. Once you're finishing the pullback, you have everything. Like I said, the calcium score, you can see already. So I think those are people using more and more. And even like the very senior people who never using in the past, they start adapting because simply easy. So I think one of the reasons is still training and teaching, but I think that can be overcome, seems to be overcoming based on the new technology. That's actually, I see in the market. That's really true. And first, your question is IFU. That's an interesting question. And actually, I think that's true, meaning like one of the fellow, he's analyzing the data for the instant restenosis, which having the neointima or neoatherosclerosis. And actually, whenever you see the neoatherosclerosis inside of the stent, And using the cutting balloon can be better compared to regular balloon in terms of the lumen expansion, etc. So that's really based on the plaque morphology. But I think like the data is still not enough to say, at least except the calcium. But I think the evaluation of the calcium by angio is limited. So altogether, I think having some mandate, not mandatory, but I think together with the AI type automatic detection helping operator to be better to use, I think that's not mandatory, but I think the way to go.
I do think you're right, Akiko. I think that the adoption is increasing in the US. I
Yeah.
think in Europe it was still very flat. I'm hoping that the ESC guideline change that you mentioned is going to help Europe, because one of the arguments in Europe is, at least in the US, there's some reimbursement for the catheter for doing IVUS, so you can absorb the costs, but in Europe there's no reimbursement, and so when you look at your DRG and how much is paid, you risk losing money on procedures. And so, that shouldn't be the reason we do things. But like you say, money is always at the bottom of all of this.
Okay, then we have a question from Dr. Yumiko Kanei. She wrote on the chat, she's asking, can you comment on the optimal result on IVUS when you're intervening on a calcium nodule? The question is, once you have a decent MSA, are you satisfied, or are you looking at anything else as well?
Yeah, that's that's the most frequent question, but most difficult question to be answered. To answer is really we don't know. It's quite interesting. This is only the time which we have the opposite compared to MSA is always better. Larger is better story. So meaning like especially in the eruptive calcified nodule, even the good MSA, they are poor outcome. So I think like we really need the good data to confirm what is the best treatment of the calcified nodule. That's really, really true. But even so, I think even like calcified nodule cases, MSA is still important predictor of the future event. So still larger is better, is be most important. And I think what is the best, what is best should we look into? Actually, when we treating the calcified nodule, most of the time you see the oval shape, is not round shape. But that I don't think that's important. We see many cases, but never predicting the future event. So that's I'm not care. But I think again, step back. I think what is important to treating the calcified nodule is really look for the non-calcified nodule circumference, meaning calcified nodule, many times when we look into those cases, non-calcified nodule site is non-calcium. That's most of the time. But when we see the calcified nodule and non-calcified nodule site is calcium, that's really, really bad type of the scenario, meaning without fracture in the non-calcified nodule calcium, you have really, really poor outcome. So I think one of the message which I would give you today to remember is when we look into the calcified nodule in the case, look for the non-calcified nodule site. And if that site is calcium, I really recommend to do some additional treatment, such as shockwave or something. Without fracture that segment, it's really, really poor outcome, poor stent expansion.
So Akiko, maybe a second question to that. You've seen now many calcified nodules, and you've seen what it looks like before and after lesion modification. Just based on imaging, which device do you think has the biggest impact on a calcified nodule? Is it rotor? Is it orbital? Is it IVL? Is it a cutting balloon?
I think either rotor or orbitally, as long as the YI bias is on the top of the calcified nodule.
The nodule. Okay.
Yeah.
Agree. Thank you.
Okay. And I see Dr. Manafa Safin as well online.
Thank you, Dr. Mehara. That was an excellent talk. And I think really insightful how you kind of directed us to use IVUS not just to guide us when to stent, but when not to stent, especially in the era of DCB. My question is about calcium modification also in terms of imaging. Now that we have these tools, we have to kind of decide which to use when. There are currently some randomized trials enrolling or about to start enrolling comparing intravascular lithotripsy to cutting balloon. I'm wondering from an imaging standpoint, is there anything you've noticed or seen that might guide your decision as to when you may use one modality over the other? And if you have any predictions on the outcome of I think it's called the shortcut trial that's enrolling these patients. Thank you.
Yeah, I think to me, clinical standpoint, by looking at the clinical cases, I see the cutting balloon is sitting somewhere in between the regular non-compliant, between the IVL, meaning something intermediate calcium seems to be the cutting balloon working better than non-compliant, but probably less than IVL. So there is a data by OCT. What is the most important parameter of the calcium to predict calcium fracture? The most important parameter is the thinnest calcium thickness. That's actually we changing the calcium score by OCT, meaning let's say you have the big calcium, like 270, where the calcium fracture you see is always thinnest, because that's a weak point of the calcium that's making the fracture. But if you have, let's say, 180 or 90 degree of the calcium, typically they're eccentric, they never fracture. So I think we are looking at the calcium fracture is mostly enough big, and if so, thinness is most important. That's what we are going to publish soon in terms of the new calcium score by OCT. On top, there is a different people to making the prediction of the calcium fracture using the different modality. Our group, we show by non-compliant balloon the cutoff value to predict calcium fracture based on the thinnest calcium thickness was about 0.28. And other people from Japan, they're using the cutting balloon. What is the prediction of the calcium fracture in the thinnest calcium by cutting balloon? I remember that's about 0.4 or something like this. And the other people who using the rotor and balloon from Japan, their cutoff value was 0.7 or something like this. So by doing more and more, they are getting fracture, even the thick calcium, because they have more power or because they are shaving on the surface. So I think if you're using the OCT, you have the very thin but circumferential. I think non-compliant definitely work. But starting like more than 0.3, 0.4, cutting balloon probably work and doesn't need the shockwave. And there is no data based on the shockwave, but I think my feeling of the shockwave is similar to the rotor or others. So I think shockwave can be done if the sinus thickness is thicker than 0.5 or more. And also it's really important to look for the longitudinal information because, for example, the IVUS, we couldn't see the thickness. In such, typically the calcium amount correlate in the circumferential and longitudinal and thickness as well. So if you have the long circumferential calcium, more likely they are thick calcium. Therefore, like the case which I show in the LID to the left main crossover stenting case, female patient, those cases we open the IVL right away because we see the circumferential but long calcium. And then we expect we should not make the fracture based on a non-compliant only. So we definitely thought the shockwave is a way to go. So I think altogether, those are the prediction and which device are we going to use.
Great. Okay.
Taylor and Mateo.
Yes, good morning. Thank you. That's an excellent talk. I had a question regarding DCBs and de novo lesions, whether it be side branch or as a hybrid approach. In lesions that are calcified, does the calcium within the vessel wall, does that inhibit the drug being absorbed? And for those lesions, are they better off with a stent? Or more simply, how does calcium or a calcified lesion affect the absorption of drug in the DCBs?
Good question. I think there is no such data in the coronary area, but I think there is a good data in the peripheral area. So there is a good paper to show, like if they treating the DCB in the calcified region, they show the absorption was worse and actually poor outcome compared to the non-calcified region. That's happening in the peripheral area. And importantly, the peripheral artery is much more calcium compared to the coronary artery. And also they are diffuse, and also they are more likely medial calcification on the coronary compared to the coronary artery. So I think the mechanism could be different, but in general, that can be understandable explanation, I think. So in such reason, I think like the making the fracture could be very important, but also there is a kind of opposite data, meaning if we put the stent into the calcified region compared to the lipidic region, which is more likely having the neointimaplasia, is actually lipidic plaque. So calcified plaque is kind of less active in terms of the neointimaplasia, but having the difficulty to push. So I think ultimately how to deal with making the enough fracture and then connection between the surface to the adventitia and the medial wall. And that's probably the best strategy, but I think that has to be confirmed based on the clinical as endpoint.
Yeah, I must admit, just from having used a lot of DCBs over the years in real world usage, Akiko and Taylor, we've always been concerned about the efficacy of DCBs with calcium. And so it doesn't mean we won't use it. If you're doing very diffuse disease, like the hybrid paper, or you saw of Colombo, which we did another one years ago, and it's diffusely disease, and we get good lesion preparation with rota and nice cracks in the calcium, we'll still consider using it, because the hope is that maybe the drug is going to go in the cracked area, and especially if you have 360 degrees of calcium. But I think we have been concerned that it doesn't work as well. But like Akiko says, that there's very little clinical data, because usually those cases are excluded from the randomized studies. So it's all based on retrospective analyses from real world registries, which is flawed.
Matteo, do you have any question?
Yeah, great. Good morning. Thank you again for this excellent talk. A lot of my questions are already discussed, but remaining, I just have a brief question regarding the modality of imaging between IVUS and OCT. We kind of discussed how some are better in certain situations. I think there are some new devices out that are a hybrid between the two. So wondering what you think about these and if they have space in the cath lab for them.
I think like my best suggestion is the device which you're comfortable. So I think at least as an interventional cardiologist, you should have one you are comfortable. That's first. And once you're comfortable one of these, and then you can expand. I think I would say 95% of the scenario you can do same information from either one. But like 5%, 10%, there is one, it's better compared to the other. But still, like calcified region, some people say OCT is better because we can see the thickness, but I do think IVUS is really good as well. And especially the calcified plaque is more likely renal insufficiency patient. So I think IVUS is better most of the time, or CTO. So I think it's really up to you. But on top, it's very special scenario. If you have both, I think it's good. Like the Minoka, and you really want to know this patient is really MI or no MI. And so doing the OCT safely, and then you identify the small plaque rupture, and you diagnose what's happening with this patient. That's, I think, clinically important. In such, I don't think IVUS help because that's small. And on the other hand, CTO, I don't think OCTs can help. So I think ultimately, very small scenario, you can do one or the other, but I think 95% you can do any of them.
Okay. And I see Dr. Judah Raut online. I'll Otherwise, in the meantime,
Maybe go, yeah, let's go to the chat and then we can.
yes, just last couple of questions. I see a question. How is your approach from Dr. Asma Khalik? How is your approach to treatment of knee atherosclerosis changing in the DCB era?
Yeah, I think like the neoatherosclerosis is really atherosclerosis. So they should behave like atherosclerosis. So, and as we have the overall consensus, if the only one layer of the stent, I think putting one more layer is better outcome, especially if that is neoatherosclerosis, because we are really treating the atherosclerosis. But again, it really depends what is the old stent expansion looks like, and can we make it better of the old stent expansion if that is bad. So altogether, that's the decision making. And if the old stent was well expanded, still you expect you have the good expansion. I think putting one more stent must be better, especially in the proximal region. But again, coming to the distal, that's different discussion. And I think I just want to mention one more thing. When we analyze bunch of the neoatherosclerosis by OCT, neoatherosclerosis can occur even there is no atherosclerosis behind the stent. Meaning, like, let's say you put a very long stent in the distal LAD, and outside is not much disease, but inside is neoatherosclerosis, or something like this. So really, stent making good atherosclerosis. But what is the point was, neoatherosclerosis itself developing inside of the neointima. So remember how it looks like the thickness of the neointima is even the most thick neointima is just like 1 or 2 millimeter thickness. So neoatherosclerosis itself is typically not much thick, and lipid amount is not much, not much, and even the calcium itself is not super thick. Many times neoatherosclerosis calcium can connect behind the stent calcium, and then making very, very difficult. But if that is neoatherosclerosis calcium only, actually that's behave very differently compared to the regular calcium because the amount is much less. So altogether, I think like the can be better modified compared to regular atherosclerosis. But after the treatment, the behavior is same as atherosclerosis. So I think the bottom line is what you predict what you predict the expansion if you put a new stent or if you not put the stent.
Okay. Thank you. And I think I can read this last question, which is more of a general question. Dr. Mohamed Al-Modi is asking a little more of a general question on DCB and wanted to know your take on the risk of acute and late vessel recoil after DCB. And are you worried about it?
That's, I think, like it's a very little data, but there is a small paper from Japan. I see like 3 group. They are analyzing the baseline and the follow-up IVUS, which all of them was nodal stenosis cases. And then they analyze the vessel size, and then they see at least not super negative remodeling, or some of them was actually a little bit positive remodeling. So one potential is compared to just balloon, we may inhibit negative remodeling, which is the main mechanism of the balancoplasty. But I really think that has to be confirmed in the large study. And of course, some of the patients should have negative and positive. But overall, what is the impact of the stenosis in terms of the remodeling in the DCB? That's, I think, it's very limited data based on the imaging. So that's, but I think what I see based on the current available data is a little bit promising compared to just balancoplasty.
Okay, thank you so much. Dr. Latif, do you have any final?
Yeah, I had one last question, Akiko. The usage of DCB in de novo disease, as you know, has fascinated me over the years, and it's something I think that we're going to see more of, and I hope we'll see more of, certainly in the US. And you mentioned something in your final statement, how about, really our definition of dissection is going to have to change because creating a dissection is part of the process, and understanding which dissections to leave is going to be, I think, the biggest challenge, right? Because I see cases from our colleagues who've been doing this in sort of Korea, Singapore, China in particular, well, China, Japan in particular. And I see some of the dissections they leave, and I go, oh my God, that looks so bad. Yet they leave it, and then they show me follow-up from 4 months later. And the patient didn't have an MI. The vessel looks fantastic. Yet there was clear staining. Okay, so I just feel they're doing it because they're now comfortable. They've been doing it for many years. To me, in order to be able to get US physicians more comfortable, we're going to have to teach them and give them objective criteria. This one you should leave, this one you shouldn't leave. And I have to believe that imaging is the answer there. It can't just be angiography because angiography is so two-dimensional. If I don't take that other projection, maybe I don't see something that would be important. I don't see the staining or something. So any thoughts to you? I know in the past you used to talk about if the dissection extends into the media, maybe it's more severe and maybe we need to cover it. But have you given any thought to how we're going to have to redefine and what objective criteria we're going to use?
Question. I think to answer that question, before we have to ask ourselves, by putting additional stent to cover the dissection, what are we going to avoid? What are we going to treat? That's we have to ask. Are we going to avoid acute occlusion or are we going to avoid restenosis? Actually, I think the most of the data, which including ours, is really including the restenosis as well. So if we are avoiding the restenosis, we maybe leave it alone because the DCB can inhibit of the shrinkage of the artery. So I think not only I think we should focus more for the size of the flap. We should focus more what is the disease behind, what is the lumen, that segment. Because what is the important predictor of the future progression of the disease is really current disease. So if you have the lipidic plaque, they are more likely progress. You have a lot of plaque burden, more likely progress. So not only the size of the dissection, but also the size of the plaque or type of the lipidic plaque. Those are probably important if we try to reduce the restenosis by putting the additional stent. But if we are trying to reduce the acute occlusion, that's I think we are going to publish one important paper based on the 20 years Columbia data, is we picking up like the acute occlusion cases, which is only 22. And all of them was hematoma. And even the hematoma and also, we analyzed like 4,000 cases, which didn't causing the acute occlusion, but hematoma was leave it alone. So many of the hematoma was okay, but still something causing the acute occlusion. And then we try to answer what type of the hematoma is bad. Is of course big, long, or not covered or ended at the normal segment, no branch is bad. And also like the instead of medial hematoma, but also instead of medial hematoma, outside of the media, like the CTO, like the neck wire type of the hematoma, that's bad. So there is something. But I think the bottom line, what we see is actually out of like 20 years experience at Columbia, really acute occlusion is not too much. And that's all hematoma. So I think that's kind of the mindset difference. What are we going to avoid by putting additional stents? So, and even hematoma, one possibility is making the re-entry site. So those together, I think really define. But I don't have definite answer, but I think my message was additional plaque burden together is important, and also probably really bad one is only the hematoma instead of all dissection.
Excellent. Okay, great. Pierre, you want to close?
Yes, absolutely. This was a very intense hour. Lots of cases, lots of very interesting takes from Dr. Mihara. We thank you so much again for being with us this morning. Off to a great Tuesday, and I hope to see you soon. Thank you so much.
Thank you very
Thanks,
much.
Akiko.
Have a nice
See you
day.
soon.
Bye.
Thank you.
Thank you.
Bye.